So thanks again, PK and the rest of the organizing committee for inviting me over here. So the title of my talk today is Bioabsorbable Stents in Below the Knee. Is it a reality or is it folklore? So let's have an appraisal of the current needs and solutions of below the knee. I think with below the knee intervention, it's always a struggle to try and get reliable luminal gain, at the same time trying to use something to inhibit restenosis. All this in the background of a small vessel, calcium, poor outflow, long lesions, and inconsistent drug delivery with drug-coated balloons. And really, all the options available below the knee are fairly limited. Balloon angioplasty, arthrectomy, drug-coated balloons, and drug-eluting stents. And really, right at this point in time, we don't have a lot of evidence other than using plain old balloon angioplasty. Now, I talked about reliable luminal gain. This is one of the few studies talking about recoil after balloon angioplasty, and this study has been quoted in several speakers before. And actually, the degree of luminal gain you get after standard balloon angioplasty is actually quite bad. We know that drug-coated balloons don't work very well below the knee at this current point in time, and even if they do, it probably would be difficult to prove in the setting of using non-angiographic outcomes to document the success of a drug-coated balloons. So how can we evaluate drug-coated balloons when we can't guarantee consistent luminal gains with POBA? So the fate of the drug-coated balloon is not only influenced by drug formulations and the type of the drug, but also the result of balloon angioplasty. Now, drug-eluting stents have been around for a while for the coronary space. We know they do work well. And the advantage of a drug-eluting stent versus a drug-coated balloon is that immediately you can guarantee scaffold, get reliable luminal gain, reliable drug delivery even in the context of calcification, prolonged drug delivery, and non-toxic effects both systemic and distal. However, one of the problems with existing drug-eluting stents is they are metallic in nature, and because of that, they represent a permanent implant that may preclude repeat interventions, and of course, that's an issue of cost, especially with long lesions. Our experience with the Abbott vascular stent, which has been for the last several years, and for those who are not familiar, it has a poly-L lactic acid structure, poly-D-L lactic acid polymer, familiar drug of everolimus, similar to the Zyme stent, which elutes over 28 days. Of course, there are several other drug-eluting stents for coronary space also available. This is a paper out of Australia with Ramon Varco's initial experience with the bioabsorbable stent from Abbott Vascular below the knee, and 12-month patency results were very comparable to metallic drug-eluting stents, similar drug-eluting stents. However, the problem with this was that the absorbed stent was actually withdrawn from the coronary space for problems of some safety results in the coronary. But recently, in Link, in January of this year, Dr. Varco presented his 36-month results from the Absorb BTK study, where 71 scaffolds were implanted with a mean lesion length of 20 millimeters, mostly in the tibial peroneal trunk, where there's a short lesion, as well as the anterior tibial artery. And in his study, he managed to have an 81% patency at 3 years, with a very good clinically driven TLR rate of 87.3%, which in my mind represents very good results for short lesions below the knee. Our experience has mirrored his, and we embarked on a small study called the Disappear study for BTK lesions in our Asian population. And this is the reality in some of the cases that we've seen. In the patient within the study with a disastrous looking foot, with a short anterior tibial artery lesion that was treated with bioabsorbable stents, and in 4 months you can see with scaffold and drug, we were able to get wound healing. Another patient with Rutherford 6 gangrene. In these cases, we have to open multiple vessels, both the anterior tibial, posterior tibial, and these were done through plain balloon angioplasty, but we used the bioabsorbable stent on the peroneal artery in a sense to give some form of insurance that we will get patency in the long run. 3 absorbable stents were implanted in the peroneal artery. Before and after angiograms gave consistent luminal gain. 1-year duplex ultrasound showed that even in fairly calcified vessels, we maintained a biphasic peroneal artery, and of course, you would expect both the anterior tibial and posterior tibial artery to occlude, and this was also seen on CT and MR angiogram. Another patient with a Rutherford 6 heel gangrene. In some of these patients, an all-out effort is made to reperfuse the leg through opening multiple angiosomes. A short stenosis in P3 was treated with a superior stent, and in the context of a clinical study, several absorbed stents were stacked up in both the AT as well as a peroneal. At 3.5 years, this patient remains symptom-free, is able to walk, and on duplex ultrasound, dorsalis pedis remains biphasic, and interestingly, a plain X-ray shows severe calcification in these patients. So even after preparing the vessel, what we've done is prepared the vessel adequately and essentially used the absorbed scaffold as a drug delivery device. Another patient with the longest follow-up of 70mm vessel that's treated with the absorbed stent. That patient with the anterior tibial artery stenosis was treated in 2012 with the absorbed stent, total length of 70mm. And on control angiogram in 2016, 4 years later, you see very nice tibial artery with no hint of restenosis. Interestingly, a control angiogram was done, and you could see that the vessel proximal to the bioabsorbable stent had progressed in terms of disease, but the bioabsorbable stent segment had remained symptom-free, which is testament to the delivery of the drug and ability of the vessel to heal with the absorbed structure. On MR and duplex ultrasound, the typical appearance of the fuzzy stent subsequently disappears several years later while maintaining patency. At 5-year OCT of this segment showed that the vessel remained well, and you cannot see any hint of the stent anymore. This particular patient did not have a re-intervention, and the wound subsequently healed after the control angiogram. So in summary, bioabsorbable stents offer the promise of drug delivery and luminal gain in one neat structure. There are short and long-term experiences in short lesions. Our experience with real-world long lesions has been encouraging, and hopefully in the next few years we will start to see this technology give us options to treat these patients. Thank you very much.